This is a board review for obesity medicine. This is just a classification. What I've done is that I went through multiple sources. I went through multiple videos online and lectures and conferences. I also read the obesity algorithm book, which is very valuable by the Obesity Management Association. Out of that book, I tried to highlight the important uh, informations because you can't just review the whole book again and again and again, right? So I highlighted the information and then I went through it again and took the important stuff from the highlighted information, or actually, let's not say important. We took the the stuff that is actually kind of weird or unusual from the highlighted information, and wrote it down, and that became a nice classification of the important stuff that you need to learn, and that resulted in the product that you see right now, and a lot of stuff from the exam came from it. So I figured I just put it out there, talk about it, and document it and give it for people who will benefit from it. Also, if I figured I couldn't help it to think. I couldn't help it but think about the one of the verses in Quran that says, وَعَلَّمْنَا الْإِنسَانَ وَعَلَّمْنَا الْإِنسَانَ بِالْقَلَمِ, which means we taught the human beings by the method of classification. That's how the human brain works, by method of classification. So without further ado, this is just random information. You'll see that it's random information, but they're helpful. So first, we're going to start with some weird information. For example, it says here that riboflavin, which is vitamin B2, only affects things in the face. So you'll see everything that happens from vitamin B2 deficiency is in the face. Sore throat, swollen throat, cheilitis, dryness around the eye, injected eye, all of these things. Night eating syndrome is different than sleep related eating disorder. Night eating syndrome, NES, is different than SRED or SRED. Okay, the difference is that SRED, sleep related eating disorder, is like sleepwalking. People eat when they're asleep, they don't remember. That's going to be a question. Next is binge eating syndrome in adults is equal to loss of control eating disease in children. You can't say binge eating in children. Okay, it's the same disease but different name. Okay, if you increase your BMI by 5, you increase your stroke risk by 20%. Okay, next, some nice statistics here. If BMI between 25 to 35, the mortality rate increases by 3%. BMI more than 40, mortality rate increases by 9%. Now, next, BMI increased by 1%, increase the chance of AFib by 4%. BMI increased by 1%, increase the stroke by 4%. That's the same equation that we talked about, but different. BMI increased by, or BMI more than 30, that results in CHF doubling, double-fold, increase, doubled the incidence of C. diff. In BMI more than 30, that means increase in the incidence of OSA by 30%. Diabetes mellitus type 2, 80% of the people who had diabetes mellitus type 2 are related to obesity. Okay? Now, bulimia symptoms. Bulimia symptoms have to happen at least once a week. Low modal vomiting والpurging at least once a week. Night eating syndrome, انه يقيت بالليل و 25% of his night requirement is eaten after dinner وكلام من ده. Energy or calories per day is eaten after dinner. That's called NES. night eating syndrome that happen at least twice a week. أما binge eating disorder لو واحدة that's somebody who's eating so much to the point that he's embarrassed of what he's eating and it has loss of control, that at least has to be 3 times a week. Okay. Um, Next, even in profound hypothyroidism, T3 is normal. Okay. Subclinical hypothyroidism, that consists about 5 to 10% of the population, and in women above 60, 20% of them, that's a lot, have subclinical hypothyroidism. This is a growing disease because it used to be not treated. Now you have to treat it if the TSH is above 10, even as an outpatient without symptoms. SRED, which is syndrome or sleep-related eating disorder, that's 3% of the population. That's a lot. A lot of people that eat when they are not aware that they're eating at night. SH, SHBG, which is sex hormone binding globulin. That's going to be a test in a test question. It increases with age, which is very weird. The age بيزود the sex hormone binding globulin, but decreases with obesity, and PCOS, which is polycystic ovary syndrome. Okay, total cholesterol decreases with obesity, but total testosterone decreases with obesity, but free testosterone is the same throughout all BMIs. Achondroplasia, that's a syndrome. The only time you're gonna hear it in the test where it comes in kids, and you have to use a different chart. You can't use the same BMI chart like the others. Achondroplasia, and it comes in short. The symptoms are short stature, brachydactyly. Their fingers are very short. Um, Big heads and frontal bossing. All right, next, we're here. Next is topiramate, phentermine topiramate. Phentermine is a sympathomimetic. Yeah. It only increases the heart rate, but bupropion, naltrexone is the one that increases the heart rate, the blood pressure. So you're gonna be that's gonna be also a test in the test. You're gonna find bupropion hypertension. It causes hypertension, which is very weird. Exogenous testosterone causes less fertility. تقلل spermatogenesis. Okay. كل هذه weird things that you just have to learn it. It's gonna come in the test. طالما weird, it's gonna come in the test. As long as it's weird, it's gonna come in the test. Lipedema treatment include decongestive lymphatic therapy, although it's lipedema. Sleeve gastrectomy with decreased ghrelin, and everybody knows that, but it also increases PYY. Leptin stimulates TSH, which in turn increases T3 and T4. Next, endocrinopathies in kids. Sometimes it gets confusing. Why is this kid having a syndrome or endocrinopathy or whatever? There's a weight-height mismatch. If the weight and height are all going high, that's different than and a patient is obese. No, that's different. The weight-height mismatch. Height stops and the weight keeps on going. Slower weight loss leads to sustained results. That's a myth. Calcium, what does calcium do for obesity? Number one, increases lipolysis, decreases lipogenesis, and binds dietary fatty acids. That's very important, binds dietary fatty acids. Vitamin D deficiency in obesity, 30% of obese people have vitamin D deficiency. It'll come in the test also. Normal BMI with big waist circumference is worse than high BMI with high waist circumference. Limbic system works on the dopaminergic receptors, and that means that it has something to do with rewards, compulsion, craving. There are two sites of the limbic system that are very special: the amygdala and the hypothalamus, the hippocampus. The amygdala, it controls food cues like advertisement, like smells, and all of these things. The hippocampus it controls the memories of food. Mirabergon, or Mirabergon, that's a medication that increases brown fat. That's the only one we know that can increase brown fat, and decreases increases basic energy expenditure by 6%, but no difference in weight. Otherwise, it'd be on the market, right? HOMA IR, that's a way to check for insulin sensitivity. Oral glucose tolerance is the most sensitive test to diagnose diabetes, more than hemoglobin A1C, but it's not as practical as hemoglobin A1C. That'll come in the test. Vegan diet deficiencies, B12, D, vitamin D, and omega 3. B12 stores, vitamin B12 takes years to deplete, so that will help you in the questions when you talk about bariatric surgery. Yes, we all know that they affect the B12. It's very well known, right? The intrinsic factor and all of this. But it takes years. If the presentation is only 2 weeks after, then it cannot be vitamin B12 manifestations. Metabolic syndrome, it's gonna come in the test. Basically, abdominal obesity, it's 5 things. You need 3 out of those 5. Abdominal obesity, meaning more than 40 inches in males and 35 inches in females, Caucasians. Hypertension, more than 130/85. Diabetes, more than 100 blood sugar. Triglyceride, more than 150. And HDL, less than 40 in males and less than 50 in female. Note, there's no LDL. It only talks about HDL, right? Definition of hypertension, 130/85. Other weird things, okay? DOACs are not inferior to Lovenox and other parenteral medications for DVT prophylaxis, but not in treatment. If there's DVT, that's after bariatric surgery. After bariatric surgery, you can use it now. You can use DOACs for prophylaxis, but you cannot use it for treatment. Spironolactone, if given for a pregnant woman, it will affect the male baby sexual development. Only male baby sexual development. Electrolytes or Chem10 has to be monitored when you give phentermine topiramate, especially the topiramate can cause high creatinine and low potassium, and that came in the test. Pediatrics should not lose more than 2 pounds per week. Pseudotumor cerebri, that will come in the test as well. Somebody who comes in and usually young and they gain so much weight quickly, then they have pseudotumor cerebri. The first step is fundoscopic exam, followed by MRI. But the most definitive in diagnosis is the LP, and that will show a high opening pressure with any difference in the CSF with normal CSF. FGF19, fibroblast growth factor 19, that's a hormone that we didn't talk a lot about in the books, but it can come in the test. It has something to do with a receptor called farcinoid X receptor, and that decreases hunger and increases satiety and decreases gastric emptying, but also, in addition, decrease bile, decreased gluconeogenesis, increased insulin sensitivity, and that is found to be increased after bariatric surgery. That's important. Bariatric surgery. Now, they're going to tell you about stimulants. We don't usually study stimulants, herbal stimulants, but there's only 5 that are important. You just learn it and memorize it somehow. So stimulants, things that will make you stimulated and revved up so you can increase your basal energy expenditure. First one is called Ma Wang. That comes from ephedra. That has ephedra alkaloid and side effect cardiac stuff. Bitter orange, that's synephrine. Like remember new synephrine? You want ephedra, one new synephrine, right? Bitter orange, synephrine, and also can cause cardiac stuff, cardiac complication. Now the next one, dinitrophenol. When you hear dinitrophenol, run the other way. Why? Because it gives you uncoupling of mitochondrial phosphorylation, and that leads to tachycardia, hyperthermia, and death actually. Next is phenylpropanolamine. Phenylpropanolamine. That's like in cold remedies. It reminded me of Triaminic, one of the medications that, cold remedies that I grew up on. Triaminic, it's called phenylpropanolamine. When you see amine at the end, it reminds you in the cold, that it's in the cold remedies. And that has ephedrine and amphetamine in it. And it can lead to hemorrhagic stroke or MI. DMAA, that's also very important. It might come DMAA that's present in energy drinks, and that can cause MI and sudden death from arrhythmia. Okay, then we have Mawang and bitter orange, both of them cardiac stuff. And then we have phenylpropanolamine and DMAA causing MI and hemorrhagic stroke or MI and sudden death, and dinitrophenol that causes death from the uncoupling phosphorylation in the mitochondria. PPP is pancreatic polypeptide. It does a lot of things, but one of the things that it does, including decreased gastric emptying and all of this, but one of the things that it does, it decreases pancreatic exocrine secretions. Exocrine secretion. MEN1, 3 Ps, MEN2, 2 Ps plus M. MEN1 is basically pituitary, pancreas, and parathyroid. MEN2, 2 Ps and M, parathyroid, pheo, and medullary thyroid cancer. Ghrelin, these are the receptors. Ghrelin comes from P/D1 cells in the stomach. GIP comes from K cells in the proximal intestine. GLP1, GLP2, oxyntomodulin, PYY comes from L cells in the distal intestine and colon. Gastrin comes from G cells of the stomach. Somatostatin comes from D cells in both the stomach, duodenum, and pancreas. CCK comes from the I cells. This is a mistake. I cells in the small intestine, proximal small intestine. Glucagon comes from the alpha cells in the pancreas, or alpha islets in the pancreas. Insulin and amylin come both from beta cells in the pancreas that came in the test. Motilin, M cells in the intestine, and that's called the housekeeper of the gut, and that's what causes the borborygmi movement or borborygmi sound. Other weird stuff, high triglycerides. Now we know that it wasn't known like this before, but now we know that it increases cardiovascular disease risk, and that's via forming lipoprotein remnants. Not the triglyceride itself, the metabolism of VLDL, which is the lipoprotein that is carrying triglycerides. It comes out with a byproduct. It's called the lipoprotein remnants, which is very small, can penetrate into the bowel wall, the vascular wall, and that is very atherogenic. Now, coffee and tea, we know that they decrease cancer. Coffee and tea decrease cancer. Out of all of the legumes, the best are dry beans and peas. They decrease cancer. Out of all of the nuts, walnuts decrease cancer. Now, out of all of the vegetables, garlic, carrots, spinach, and broccoli decrease cancer. Now, just so you know, I didn't come in the test, or it's not going to come in the test, but maybe important somehow. Maybe a clue: peanuts are legumes, avocado, cucumbers, bell peppers are fruit, watermelon, chili peppers, bananas are berries, and the berries themselves, the strawberries, blueberries, and blackberries, are all aggregate fruits. Strawberries, blackberries, and raspberries, aggregate fruits. For the antidepressant fluoxetine, Prozac, it's very good for weight loss. It decreases weight loss. Nortriptyline and desipramine is neutral. These are the advanced types of amitriptyline and imipramine. Nortriptyline, desipramine are the advanced of amitriptyline and imipramine, because amitriptyline, imipramine, paroxetine, doxepin, mirtazapine, trazodone, brexpiprazole, and aripiprazole that came in the test, they all increase weight. GLP-1 How does it cause cholecystitis? The theory is that it decreases CCK and that decreases gallbladder motility, which leads to cholecystitis. Rules. DPP4 inhibitors. Some rules here. These are diabetic medication. DPP4 inhibitors. They no effect on the body weight, no effect on cardiovascular risk. GLP-1 agonists. They decrease body weight and decrease cardiovascular risk, especially liraglutide. That's the first one studied, but also now semaglutide has been talked about, or there is one study. SGL2 inhibitors. They decrease cardiovascular risk, positively decrease cardiovascular risk, but we don't know, and maybe equivocal decrease in body weight, at least not approved for obesity. Alpha glucosidase inhibitors decrease body weight and maybe a slight decrease in the cardiovascular risk. PPAR gamma agents, they increase the body weight. So the only one out of all of this in front of me now, increase body weight and decrease, but in the same time decrease cardiovascular risk. Right? So we talked about the stimulants the last page. This one we're going to talk about the supplements. There are 5 supplements that they chose, and we're going to just memorize those. Forskolin, Garcinia, glucomannan, glucosinolates, ervignia. Forskolin extract from mint family. Extracts from the mint family, and most of its side effect is blood pressure related. So syncope, fainting, that's things like that. Garcinia, it's a small green fruit. It comes from that, and it does liver toxicity. But forskolin decrease blood pressure. Garcinia, liver toxicity. Glucomannan, that comes from elephant yam, from the elephant yam, and everything that does is just GI, mild stuff, GI side effects. Glucosinolate, that's actually from the mustard family. It has sulfur. It's from the mustard family, and it has to do with the goiter and those stuff, and hypothyroidism. Ervignia, that comes from African mango, and that causes brain stuff like sleep disturbances and headache. Now, the absorption. Just remove this copper, okay? Stomach, AW. Alcohol and water. That's the only 2 things that get absorbed from the stomach. Alcohol and water. Duodenum, FAVIC. Add the copper here, please. FAVICC, FAVIC. I don't know, just to remind yourself, maybe duodenum absorbs favavines. You can say FAVIC. FAVIC is fatty acids, amino acids. V for vitamins, I for iron, C for calcium, and the other C for copper. That's all duodenum. Jejunum, Pacific, but don't care about the IC at the end. Just Pacif. Potassium, amino acids, carbohydrates, I for iron, and F is for folate. That's the jejunum. That's one of the most stable. It doesn't change. Ileum, Babs, BVM. Babs, bile acids. BA is for bile acid. BS is for bile salts. B12, BVM is the first. B12, V, vitamins and minerals. Note that all of the small intestine, duodenum, jejunum, and ileum, you're not going to go wrong if you say vitamins and minerals. Colon, normal saline with all its component, and then KB137. Normal saline, KB137, meaning normal saline, meaning you have sodium, chloride, water, and then vitamin K, vitamin B1, vitamin B3, and vitamin B7. Okay, what are the vitamin deficiencies in different surgeries? Start with the band, lab band, which is not made anymore, is not done anymore. B1, vitamin B1 and D. Sleep أكتر شوية, a little bit more. B1, B9, B12. B9 is folate. B1, B9, B12, and D with iron. Rowan Y gastric bypass, B1, B9, B12, D, iron, like the other one, but add calcium now. And then the duodenal switch and the CD and CDS and all of these new surgeries, everything is a problem. So we got the B1, B9, B12, D, iron and calcium, but add to it vitamin A, vitamin E, vitamin K, zinc, and copper. Tongue issues from the vitamins. Very red tongue, riboflavin, which is vitamin B2 deficiency. Atrophic tongue, vitamin B6. Smooth tongue, vitamin B12. Glossitis, zinc. It seems like folate can cause it. Kim in the test. Anemia. In general, vitamin B2 can cause anemia. Okay, which is rare. Sideroblastic anemia, vitamin B6. Megaloblastic anemia, vitamin B12 and vitamin B9. Iron and copper can cause microcytic anemia that came in the test. Copper. Bleeding gum, vitamin C. The only thing, so when you see in the test something that says bleeding gum, you know it's vitamin C, scurvy. When you see diarrhea, that's the only one that causes diarrhea, pellagra, which is vitamin B3 deficiency. Angular cheilitis, vitamin B2 and vitamin B6. That's the only two. These are keywords that can narrow your differential. Dermatitis, if dermatitis in the face and the eyes and the mouth and this area, we know that vitamin B12 loves the face, like we talked about before, and vitamin B6. So again, like the cheilitis, vitamin B2 and vitamin B6 can cause all kind of dermatitis of the face, including the cheilitis and everything else. But if the dermatitis is in the sun-exposed areas, that's vitamin B3 deficiency, which is pellagra. Ophthalmoplegia, only vitamin B1. Throat swelling, who takes care of the face? B2, so it has to be B2. Death can happen in only 4 vitamin deficiency. Very easy. B1 to 3 and C. B1 to 3 and C, these are the deaths from vitamin deficiency. Let's start here. Neuropathy can happen in vitamin B1, B6, E, and copper. B1, B6, E, and copper. Okay. Cushing disease, that's selenium deficiency. Cardiomyopathy, vitamin B1, copper, and selenium. Let's talk about some deficiencies that happen together. There are certain things that happen that they actually happen together, meaning magnesium and potassium deficiency, for example, in alcoholics, they happen together. So here, if you see an iron deficiency, chances are you have copper deficiency. If you see vitamin D deficiency, chances are you have calcium deficiency. If you see folate deficiency, chances are you have zinc deficiency. You have copper and iron, vitamin D and calcium, folate and zinc. These are brother and sisters. Okay? There are certain things that when you give them together, it will improve the outcome. Like, for example, iron and vitamin C. If you take iron, take vitamin C with it or close to it, it will improve its absorption and utilization. Vitamin B1, add glucose and magnesium to it. It'll be a better utilization. Now, routine replacement after bariatric surgery. This is important. Routine replacement, the things that are replaced routinely: vitamin B9, B12, D, calcium, and iron. Vitamin B9, folate, vitamin B12, vitamin D, calcium, and iron. These are replaced no matter what. If you have SADI, which is the duodenal switch and the new anastomotic malabsorptive surgeries, add to that vitamin A that you need to replete. Now, monitor monitor everything about iron. everything about calcium metabolism, and then vitamin K and vitamin E. That's the monitoring. So iron, we check iron, ferritin, and TIBC. In calcium, we check calcium, phosphorus, 5-hydroxy vitamin D, and parathormone, and also, but then in vitamin K, check PT, and vitamin E, check alpha tocopherol. Two enzymes that are hidden in my common test. GOAT activates ghrelin, whereas DPP4 deactivates GLP1. This is what you do for history taking. This is not in a test. Okay, so now let's talk about some pathways. This pathway is important to learn. None of that comes in the test except certain things. J and K. Remember the word J and K, that's bad, and the word P13K, that's good. P13K is good. J and K is bad. P13K is somehow attached to tyrosine phosphorylation. That's the method of phosphorylation that happened in that pathway, and that's good. Whereas J and K is bad. It has serine phosphorylation of the proteins, and that makes it inactive and harmful. Okay, the main pathway is that insulin attaches to IR, insulin receptor. Insulin receptor makes an IRS, insulin receptor substance, that will activate MAP, and MAP activate the increased cell differentiation and number, which decreases insulin resistance and decreases adiposopathies. At the same time, the insulin activate the pathway that is called P13K, which is a good one, remember, that results in tyrosine phosphorylation, or undergoes tyrosine phosphorylation that result in increased GLUT, which is the transport receptor or protein that goes, or receptor that actually takes the glucose into the cell and make use of it. So it improves insulin sensitivity at this point, right? Okay, so that's the main pathway. There are also insulin on the side inhibits a bad hormone called HSL. HSL, hormone sensitive lipoprotein, which actually breaks down the lipoproteins in a bad way and actually cause atherosclerosis. So it inhibits that hormone. So that's all we know about insulin. Now there are other mechanisms that will go. You see, there's four. Let's make it three, because these two are one. There's three areas where obesity will interfere with this. So how does obesity interfere with the insulin sensitivity to make it insulin resistant? Adiponectin, that comes from the fat, right? What it does, obesity, but inhibit or decrease adiponectin. That's one way. So adiponectin normally would attach to the receptor and then increase a substance called AMPK, AMPK, that actually increase vasodilation, decrease fatty acid oxidation, and improve insulin sensitivity. Now, obesity can interfere with the adiponectin quantity itself, but also it secretes TNF. TNF inhibits or compete with adiponectin at the receptors, and anyhow, that results in inhibition of AMPK. AMPK will do these three effects, but also has another effect, which is stimulation of P13K pathway. Right, so adiponectin, that's how it works. It goes like this: receptor AMPK, and activates the P13K pathway that improves insulin sensitivity. But obesity will inhibit this reaction here. Decrease adiponectin with TNF will inhibit adiponectin at the receptor level. Then there's not enough AMPK and there's insulin resistance. So that's adiponectin. Now, also normally complement will number 3 or C3 will make a compound called ASP, which then works on monoacylglycerol to make diacylglycerol transferase, or activate diacylglycerol transferase, which in turn makes triglycerides and gets stored. The diacylglycerol transferase, which is called DAGT, DAGT, it inhibits HSL. So diacylglycerol transferase is a good enzyme like insulin, right? Or a good hormone like insulin, inhibits HSL. But obesity, so it's made out of the complement, right? ASP, it comes from complement. Now, obesity can inhibit this reaction of C3, which that means decreases diacylglycerol, decreases the inhibition of the HSL, causing more atherosclerosis. Now, also obesity increases the hydrosteroyl hydrolase, right? And by doing this, it does increase adipocyte size, which increases the MCP1. MCP1 increases M1 macrophages, which is an inflammatory macrophages that will increase TNF, fatty acid oxidation, which result in formation of J and K. Okay, steroid without increases adipocyte size, and we know this, the bigger the size of the adipocyte is the worse. The bigger the number, the better. Now it forms J and K. J and K like serine type phosphorylation, so it inhibits this pathway P13K. Then, in conclusion, the insulin has three limbs in their action: MAP, HSL, and P13K. That's the main one. Adiponectin will further improve the P13K, but obesity inhibited. And then C3 will form compounds ASP, dinitro, diacylglycerol transferase that also inhibit HSL, but unfortunately the obesity affect this pathway as well. Now obesity normally, so obesity does something by itself now, which is inhibition, increase in hydrolases for the steroids, which increases adipocyte size, increases MCP1, which in fact increases M1 macrophages that secrete TNF, and fatty acid oxygenation that result in J and K serine phosphorylation, which inhibits the P13K pathway. Acronym: stop bang, snoring, tired. This is the acronym. S for snoring, T for tired, O for observed apnea, P is for pressure, blood pressure, B is for BMI, A is for age, N is for neck circumference, and G for gender. SMART goal. You'll be asked about the SMART goal in your interviewing. S is for specific, M is for measurable, A is for achievable, P is for R is for relevant, and T is timed. ORs definitely going to be asked. Open-ended questions. A is for affirmation, R is for reflection, and S is for summarization. FIT for exercise. This is an exercise program. Frequency, it detects or exercise interviewing. Frequency, intensity, time, type, and enjoyment. That's like a prescription. Essential branch chain amino acids. It's not all essential amino acids, essential, but and also branch chain. Their acronym is LIV, and L is for leucine, not lysine. Leucine, isoleucine, right? The brothers, and valine. Essential amino acid. The acronym I use is methylphenteramine value. Methyl, a hill that has meth-phe in it, and phenteramine value. Phenteramine is related to meth. Obviously, not all the letters are taken here. So meth-me is for methionine, TH is for threonine, H is for histidine, I is for isoleucine, L is for leucine, another L is for lysine. Phenteramine, we're only going to take PH. Phenylalanine, tramine, we'll take tryptophan, and value, we'll take valine. Vitamin B3, niacin deficiency, pellagra, you give pellagra, which is 4 Ds: dermatitis, diarrhea, dementia, death. Essential fatty acids, La and Allah, linoleic acid, and alpha linoleic acid. Okay. Now, conditionally essential fatty acids are made in small quantities, and it depends on conditions. EPA, DHA, and GLA. EPA, DHA, and GLA. EPA and DHA comes from the cod liver oil and marine animals, fish oil. GLA is basically gamma linoleic acid also, right? Now, there's something else called CLA, which is conjugated linoleic acid, which is the one of the naturally occurring trans fats. Trans fat, but it's not dangerous. Trans fats that we make are dangerous. AHI, apnea hypopnea index. RERA is respiratory effort related to arousal. That's a nice concept. When it's different when somebody has sleep apnea and just wakes up nicely, or wakes up startled. That's respiratory effort related to arousal. RDI, that's respiratory disturbance index, which puts these two together, AHI and the RERA together. Now, also some other motivational interviewing stuff. RULE stands for R for resist, U for understand, L for listen, and E for empower. Frames, feedback. F is for feedback, R for responsibility, A is for advice, M is for menu, E is for empathy, and S is for self-efficacy. Now, these are all of the, or some of the most important and commonly in the test exam, syndromes. The first three are monogenic. The latter 7 are syndromic. Most of the time, the monogenic don't have mental retardation. The others usually have mental retardation. So let's do some classification here. MC4, POMC, leptin, Bardet-Biedl, Cohen, Prader-Willi, Albright, Ostrom, Beckwith-Weidman, and Fragile X syndrome. The inheritance, MC4 dominant, that's the most common monogenic, right? And Albright is dominant. There's only 2 dominant, MC4 and Albright. The rest is recessive, except obviously the obvious one, Prader-Willi, paternal deletion, that's a mutation of chromosome 15, and the Fragile X is X-linked. Prevalence, most common monogenic is MC4, most common syndromic is Prader-Willi. Hyperphagia, the first 4 is hyperphagia. Bardet-Biedl, although it's a syndrome, it's kind of lends itself to leptin a little bit, so it's within those together with these 3 leptin stuff, and Prader-Willi, the famous ones. يبقى المونوجينيك كلهم plus the 2 famous, the most 2 famous syndromic, and that gives you hyperphagia. There's some keywords in Prader-Willi. The kid was not eating when he was 2. There was a point that they gave him parenteral nutrition and he was hypotonic. That chemotherapy was very confusing. I don't know if I answered it right. Height, of course, it's obesity, but very rarely if you see somebody with increased height. There's only 2 syndromes that increase the height. MC4 giants, and Beckwith-Weidman, his name is Weidman, it must be increased height. Okay, MC4 and Beckwith-Weidman. Leptin deficiency, decrease height. Prader-Willi, Albright, and Ostrom all are short. Face, I made some drawing of the face. Cohen has a very small head, okay, and the hairs are thick, including the hairs of the eyebrows and eyelashes and the hairs on the head. Prader-Willi, long narrow face with almond-shaped eyes. Albright is rounded face. Fragile X syndrome, huge forehead, small face, big ears. Okay, Developmental delay, Cohen has a developmental delay, Prader-Willi developmental delay, Fraser X also developmental delay, and the others also syndromic, some sort of developmental delay. Vision loss, there's only three. Bardet-Biedl, very famous for vision loss. Cohen, vision loss, and then Ostrom. This is a key word: cone and rod dystrophy in the retina. Hypogonadism, leptin is hypogonadism. Bardet-Biedl and Prader-Willi, the two famous, and leptin. Fingers. This is also another keyword. Polydactyly. Yes, 6, 8 fingers. Okay. Albright is short fingers. Albright is opposite the Bardet-Biedl. Metabolic syndrome, MC4 and Bardet-Biedl. Decreased immunity, decreased T cell function in leptin, and neutropenia in Cohen. Giveaways. If he says tall, it must be MC4. If he says red hair and adrenal crisis when he was young, POMC deficiency, receptor deficiency. If he says polydactyly and renal disease and even eye disease is Bardet-Biedl, definitely polydactyly. Cohen, over-friendly behavior. Over-friendly behavior, you know it's Cohen. Enjoyed hyperflexibility. You have this baby that's hyperflexible and also has over-friendly behavior. Prader-Willi, almond-shaped. If it's almond-shaped eyes, that's it. And the story, that he was not. He was up to 2 years. He was hypotonic, and we were feeding him. Just so you know, there's another syndrome called Angelman syndrome, and that's a maternal deletion of the chromosome 15. It's the same chromosome, but maternal deletion. It's not as famous and not as common. Albright, dental abnormality, and pseudohypoparathyroidism. If it says pseudohypoparathyroidism, that's Albright syndrome. Ostrom, it depends on ALMS1 mutation. So Ostrom is a mutation that results in ALMS1 dysfunction. Prader-Willi, ALMS2 dysfunction, and both those they actually bring the leptin receptors all the way up to the surface of the cell to be functional. Ostrom, hearing loss, truncal obesity, pulmonary hepatic renal failure. Beckwith-Weidman, if you see hepatosplenomegaly or a tumor, hepatosplenomegaly tumor, that's Beckwith-Weidman. Fragile X syndrome, large ears, and flat face, prominent jaw. That's it's a Fragile X syndrome. Some states, body weight has 60% water. In obese people, it's only 40%. Muscle and organ weight, 75% water. The bone weight of the body is only 7 pounds. Range of percent of body fat in the population ranges between 5 to 70%. So it's a wide range. Android fat should not be more than 3 pounds. And that will increase cardiovascular risk. The average in the population is 7 pounds. Visceral fat, not more than 1 pound. The average population, 2 in women and 3 in men. T-score is not the Z-score. T-score is the score for osteoporosis. So normal, it's compared to a 30-year-old Caucasian woman. And if you have -1 or higher, meaning -1 or 0 or 1, that means you have a good score. That's normal. Osteopenia, if it's -1 to -2.5, osteoporosis, if it's more than -2.5, like -3 and all of this, that means severe osteoporosis. But because it has to do with a Caucasian woman and all that, but it's a Z score came out, and it's actually compare you to matched controls. Normal lean body mass is 75%, fat mass is 25%. That's normal. Lean body mass is 40% muscle, 10% bone, and 25% organs. resting metabolic rate is 70%. Physical activity, usually 20%, and diet-induced thermogenesis is 10% of the energy expenditure, so all 100%, right? Um, if you make less than 5,000 steps, you're sedentary. Less than 7,500 steps, low. Active, less than 10,000, you are somewhat active, and then more than 10,000, you're active. If you do 20 steps, you burn 1 calorie. If you do 3,500 calories, you burn 1 pound. So imagine how many steps to burn 1 pound. Rex. Moderate exercise 150 to 300, or severe vigorous exercise 75 to 150. Just remember, 150 is the minimum for moderate exercise, 75 moderate for vigorous for vigorous exercise. They kept on asking twice in the test about what is the definition of moderate exercise. Very low calorie diet, it's less than 800 calories. Low carb diet is less than 150 grams per day. Very low carb diet, less than 50 grams per day. Low fat diet, less than 30% fat of the food that you eat. Very low fat diet is less than 10%. Strange things, strange things. From the intestines, weird. Glucose and galactose are transported by SGL21. Fructose is that's the one that's transported by GLUT5. Remember, there's multiple gluts, right? The glut in the intestine is 5. In the liver is 2, and in the skeletal muscle and fat is 4. Saturated fat are solid in at room air, and they don't get rancid very easily. So that's why companies like them. Medium chain saturated fatty acids is 8 to 12 carbons. Long chain is more than 12. Long chain saturated fatty acids, the two that we know or we talk about a lot is stearic acid and palmitic acid. Stearic acid is C18, palmitic acid is C16. The stearic acid is 25% saturated fat of the saturated fats in the United States, and has minimal cardiovascular problems. Palmitic acid that comes from palms is 16 carbons, but it represents 50% of saturated fats that we have in the United States, and it actually increases cardiovascular risk significantly. Saturated fats, the example of palmitic acid and coconut, palm oil and coconut oil. Don't drink them, don't eat them. Polyunsaturated fat is what? Vegetable oil, fish oil, and then sunflower oil and safflower oil. Sunflower and safflower. Vegetable oil, fish oil, sunflower, and safflower. That's all polyunsaturated fat. Monounsaturated fat: olive oil, canola oil, avocado oil, and pomace oil. I don't know what pomace oil is. Meds that increase cholesterol are beta blockers, amiodarone, steroids, diuretics, protease inhibitors, and cyclosporins. Citrosterolemia, that's when you have a high cholesterol that's resistant, usually comes from plant steroids. To decrease plant steroids treatment, decrease animal steroids, cholesterol, and bile sequestrants like cholestyramine, and use ezetimibe. Don't respond to statins, citrosterolemia. The Ornish diet, horrible. Ornish diet is a vegetarian diet that actually limits fat to less than 10%, cholesterol less than 10 milligram per day. Ketogenic diet, also very difficult. Induction phase is 20 grams of for induction for 20 grams of carbohydrates. You don't even eat fruit, especially starchy fruit. And then after that, ongoing weight loss period, same. Pre-maintenance, almost the same. And then when you reach the maintenance, it might increase your carbohydrates to 80 to 90 per day, grams per day. Paleolithic diet, don't eat anything that they didn't eat 10,000 years ago, so that's why you don't eat legumes, you don't eat grains, you don't eat dairy, and you don't even eat potatoes. Vegetarian diet, it decreases actually all-cause mortality, vegetarian diet. So that's something that is not 100% talked about, but monitor for vitamin B12 deficiency. In the US, obesity is 42% of the population. US youth obesity, 20% of the population. Severe obesity is 9%. Blacks, 50% of them are obese. Hispanic, 45%. White, 41%. And Asian, 16%. Youth, 20%. People aged 20 to 40, they have 40% obesity. 40 to 60 have 44% obesity. More than 60 have 41% obesity. Metabolic syndrome, 30% of American population have metabolic syndrome, and 80% have some derangement that is part of the metabolic syndrome but doesn't meet the full criteria. To classify obesity, normal is 18.5 to 25 BMI, overweight 25 to 30 BMI, class 1 is more than 30, class 2 is more than 35, class 3 is more than 40. For Asians, decreased by 3. All of these numbers, we don't have to write million numbers. Just remember those numbers and decrease by 3 each one of those values to become to the values for Asian Americans. Central obesity, men, which is basically waist circumference, men 40 inches, women 35 inches. For Asians, decreased by 4. Okay, for center for waist circumference, decreased by 4. For BMI, decreased by 3 for Asians. Came in the test, Asians. Drugs, NES, night eating syndrome, sertraline can work. BED, binge eating disorder, lisdexamfetamine, that's the main one. Topiramate off-label, and now off-label GLP-1s. POMC deficiency, MC4, very common, PCSK deficiency, and even Bardet-Biedl syndrome. Setmelanotide, that's a new medication. Leptin deficiency or lipodystrophy. Lipodystrophy is treated with metroleptin. Insulin resistance is treated with TZDs and metformin. Alopecia in PCOS, cyproterone, finasteride and minoxidil. Hirsutism in PCOS, give them aldactone, eflutamine. Hypogonadism, hyperandrogenemia in PCOS, GRH analog, ketoconazole, I don't know why ketoconazole, aldactone, and flutamine. Metformin, weird treatments, PCOS, prediabetes, and antipsychotic weight gain. These are things that are amazing for metformin in outpatients. Okay, this is a good exercise for obesity medicine with comorbidities. So if you have obesity and diabetes and coronary vascular disease and CHF, only 2 medications that you can use, metformin and SGLT2 inhibitors. If you have obesity, diabetes, coronary vascular disease without CHF, you can use metformin again, SGLT2, but also you can use GLP-1. Right? Especially liraglutide. But if you have obesity and cardiovascular disease only, you don't have diabetes and you don't have CHF, you can use just liraglutide. It's been approved for that. Now, BMR, based on metabolic rate, it estimates how they divide it: skeletal muscle 20%, liver 20%, brain 15% is less, but the size of the brain is small. That's why per gram is more. So skeletal muscle 20%, liver 20%, brain 15%, heart 10%, gut 10%, kidney 5%, and fat, all of that fat 5%. Antipsychotics, again, increase weight, valproax, lithium, and carbamazepine. Weight neutral, ox carbamazepine. When you add ox to carbamazepine, it becomes weight neutral. And then the best one is lamotrigine. Came in the test. Lamotrigine is a good antipsychotic. It actually decreases weight. Sleep aids, we talked about before. Imipramine and amitriptyline, the ancient ones, increase weight, and weight neutral, nortriptyline and dizipramine. I cells, CCK, K cells, GIP, L cells, GLP-1 and 2, oxyntomodulin, and PYY. PCOS, 10% of women have PCOS. PCOS relatives, 30% of them have PCOS, and 30% of PCOS are obese or pre-obese. 70% of 70% of people who has who have PCOS have obesity or pre-obesity, and 30% of PCOS relative have PCOS. Okay, maximum weight gains per pregnancy. This came in the test. If you're underweight, you gain 40 pounds, up to 40 pounds. If you're normal weight, you can gain up to 35 pounds. If you're pre-obesity, you can gain up to 25 pounds. If you're obese, 20 pounds. Maximum allowed per the gaining per week in the second and third trimester. If you're underweight, 1.3 pound per week. If you're normal, 1 pound per week. A nice number. And then pre-obesity, 0.7 pound per week. If you're obese, 0.6 pound per week. Now, for breastfeeding, obviously obesity affected breastfeeding. So for initiation, it's close. 82% of obese women initiate breastfeeding, as opposed to 86% in the population. But to be able to continue 6 months of breastfeeding, 44% of obese women continue, and 57% versus 53% in normal people. Menopause, normally, people in menopause normally gain 6 pounds over 40 years. That's normal. Pre-obesity and obesity in menopause. If you're the younger menopausal woman, less than 60, 65% of them are obese. If you're less than 75, 75% of them are obese. Imagine that. If you're less than 75 menopausal, 75% of the chances that obese, that you are obese. More than 75%, more than 75 years of age, decreased the rate of obesity. But what we know is that 48, if you're menopausal above 80, 48% of those people have sarcopenic obesity, which is a disaster. We talked about metabolic syndrome. We talked about the drug choice. Rothman criteria for PCOS: 2 or more of the following: menstrual irregularities, hyperandrogenemia like acne, hairs, and so on, and polycystic ovary on imaging. 2 out of the 4. As far as the body composition, you have to think about it this way: 2 compartment. The ones that measure 2 compartments, the ones that measure 3 compartments, meaning fat, muscle, and visceral fat, visceral abdominal fat, all of these things. And then 4 compartments and 6 compartments. 2 compartments, obviously, it's the most common, so all of them are in the 2 compartments category. DEXA, calipers, hydrostatic weighing, butt pod, BIA, bioimpedance analysis, and deuterium water. 3 compartment, DEXA only. 4 compartments, you have to combine them together. So either you do hydrostatic weighing plus DEXA plus BIA, or hydrostatic weighing plus DEXA plus deuterium water. 6 compartments, I don't know. Weir equation for energy expenditure equal VO2 plus VCO2 minus nitrogen. Respiratory quotient is VCO2 divided by VO2. OHS, obesity, hypoventilation syndrome. In order to fit there, very easy criteria. Everybody will fit there. Obesity, more than 30 BMI, PCO2 of 45, and exclusion of other causes. NES, night eating syndrome. These are the criteria. The top criteria, it has to be there, and then these 5 criteria, you have to have 3 of them, and then the lower 4 criteria has to be there as well. So number 1, 25% of the calories are after dinner, and more than twice a week. And then 3 of the following: No breakfast more than 4 times a week. Increase appetite at night, increase depression at night, insomnia, and can't sleep without eating, or have the belief at least. 3 out of those 5. Plus, the other 4 has to be there. It cannot be drugs. You have to be aware of the episode, otherwise it's thread. It has been going on for 3 months. And you have to have impaired functioning. You can't function in life. Okay, so body composition, body fat. Let's see. For the American Council on Exercise and the OMA has different but close classification. So American Council on Exercise, essential fat, they say it's 5%, and then we're gonna increase by 6. Except the first step is gonna increase by, it's gonna be 13. It's gonna by itself. It's gonna increase by 8, but all of them increase by 6 roughly. So essential fat 5%. Athletes supposed to be 11%. Make it 13 for me. And then if it's 11%, next one is gonna be 17%. That's fit people. And then acceptable is 24%. They don't have a category for pre-obesity, but obesity is more than 24%. You have then 5 essential, 13 athletes, 17 fit, 24 acceptable, and more than 24 is obese. And here, increase women, add a factor of 7 to all of those. 7% more fat, okay? That decreases the number that you have to remember. The OMA came out with different. Essential fat here a little bit higher, 9%. And here we're gonna go up by 5. Athletes, 14%. Fit, 19%. Normal for 24%. They are acceptable. It's 24%. They all agree about that. 24%. Pre-obesity, they added pre-obesity 29%. Remember, we go up by 5, and then obesity is more than 29%, and women are more by 5%. Here the women are more than by 7%. Here women more by 5%. U.S. Army fat, they go by, they don't care. They just want the acceptable. So what's acceptable for them? And we're not gonna do 24. We're gonna do 20% if people are younger. So we have to by age. So less than 20 years of age, you are supposed to be 20% fat. If you're less than 27, 22, we're going up by 2, less than 40, 24, more than 40, 26% fat. And the women are higher by 10. The U.S. Army, the women have leeway. They need more women. OSA, you do the apnea-hypopnea number. If it's less than 5, normal, more than less than 15, mild, less than 30, moderate, more than 30, severe. MAFLD, 25% of adults have MAFLD. The worst is Hispanic adults. 45% of Hispanic adults, 38% of, or 33% of Caucasians, and 24% of blacks. Blacks are doing good with the MAFLD for some reason. 2/3 of MAFLD have obesity. Diabetes, the same thing. 80% of them have obesity. Fatty liver, the story is that fatty liver, 30% of it becomes MASH, and then 25% of it becomes cirrhosis. The glycemic index. Glycemic index of glucose is 100% glycemic index. Of fructose is 25% glycemic index. Of a fruit that has both glucose and fructose is less than 50%. Glycemic index of sucrose is 65%. Glycemic index of high fructose corn syrup is 70%. Improving obesity complications require weight loss of hepatic steatosis, only 5% is enough. MASH with fibrosis, 10%. PCOS, 7%. Prediabetes is 10%. Hypertension is 10%. Sleep apnea, 5 to 10%, although not 100% guaranteed. Diabetes, you lose 30 pounds or 15 kilos, diabetes will resolve. And macrosomia of the baby 7 kilos. There was like 6 or 5 uh, questions about a pregnant woman doesn't want her baby to become obese. Pathways: lipogenesis in adipose tissue lipolysis in lipogenesis, free fatty acids through chylomicrons and VLDL diffuses or into the adipose tissue, or there is a carrier protein, and that becomes and then the glucose. That's why triglycerides depends on both glucose and fat. I don't know why I call it only fat. It's actually both. Glucose goes through the fat using the GLUT4 enzyme receptor, and now became glycerol, free fatty acids and glycerol in the fat using the enzyme GPAT, which is the rate limiting GPAT, rate limiting, becomes diacylglycerol with the DGAT. Remember DGAT, and it becomes triglycerides. Lipolysis in adipose tissue triglycerides using ATGL becomes diacylglycerol. Now HSL, which is the bad one, hormone sensitive lipase, which is inhibited by insulin and activated by epinephrine. It gives you monoacylglycerol, MGL, it gives you free fatty acids. And free fatty acids come out and get bound by albumin. Obesity affect the renin-angiotensin system. Obese people have a high level of aldosterone. That's why they like spironolactone for hypertension. Obesity alter PPAR gamma. EKG changes in obese people prolonged intervals like STT wave flattening, left axis deviation, left atrial enlargement, decreased QRS, shortened QRS, and false positive inferior MI. Epicardial fat, it can affect or give you coronary artery disease through the paracrine signaling and vasocrine signaling. Paracrine just spreads normally through the interstitial tissue and all this, or sharing the blood supply, so it goes into the myocardium through the blood supply. Vasocrine through the vasa vasorum, which is spread through the tissues until it reaches to the vasa vasorum, coming out of the arterial wall, or as it's going into the arterial wall to supply the arterial wall with blood. Obesity, there's an increase in mineralocorticoid. That's why it's in cases of heart failure with reduced ejection fraction, they love aldactone. CAC score above 100, which is calcium score in the coronaries, increased risk of coronary artery disease. But there is another score, it's called the perivascular phi, which is the fat attenuation index that indicates inflammation. Perivascular phi. Oxidized LDL in the plaque is transferred from the pericardium to the adipose tissue through macrophages command. Obesity decreases the natriuretic effect of BMP and decreases the BMP number. Adiponectin, sympathetic stimulation, it increases the blood pressure. It decreases inflammation. African American are salt sensitive. Ultra-processed food increases the blood pressure. Obesity decreases BMP, produced by the left ventricle. Weight loss, LPL, is a good lipoprotein lipase. It's called lipoprotein, but that's a good one. It's present in the endothelium. As opposed to HSL that is bad and it's present in the fat in the adipose tissue. Apolipoprotein B containing lipoprotein. Apolipoprotein B is the bad one as well. Fat cells 10% turnover every year. In a lean person, there's 35 billion fat cells storing 25% of cholesterol. In obese people, there's more than 150 billion fat cells storing 50% of the cholesterol. The whole cholesterol that is stored in the fat is only 0.5% of fats in general. TNF, increased VLDL secretion from the liver. LPL, decreased CATP is responsible for the decrease in HDL. And decrease in small dense LDL in the adiposopatic, seen in adiposopatic dyslipidemia. CETP responsible for decrease HDL and decrease the small dense LDL, and that's exactly what causes adiposopatic dyslipidemia. Androgens, increased LDL, decrease HDL, bad, but also decreases triglycerides, good. Estrogen, decrease LDL, increase HDL, good, but also increases triglycerides, bad. Fatty liver, decrease lipoprotein lipase, increase VLDL, decrease HDL, increase small dense LDL, also because of the decrease in CATP, increase free fatty acids that actually gets conjugated with the sphingolipids that result in ceramides that are fatal to the cells. US for MAFLD, the best test is ALT, came in the test obviously. And then fibroscan or elastography, they're the same. Fibroscan or elastography is not a typical ultrasound, is more sophisticated. And then MRI PDFF, that's another MRI, and another type of MRI, MRS, spectroscopy, or you do fibrosis score. Hypothyroidism and poor sleep cause MAFLD. Causes of MAFLD other than just obesity, hypothyroidism, poor sleep, celiac disease, TPN, glycogen storage disease, drugs that can cause MAFLD, antidepressant, steroids, antiretrovirals, amiodarone, valproate, methotrexate, tetracycline. Treated of MASH, weight loss, physical exercise. If you're diabetic as well, give TZDs. TZDs will increase weight, but will distribute the fat in the subcutaneous tissue. GLP-1 is a treatment for MASH at this point. Without diabetes, vitamin E. With diabetes, TZDs and GLP-1. Without diabetes, vitamin E. Obesity is the second most common preventable cause of cancer after cigarettes. Cancer due to obesity is 5% in males and 10% in females. Obesity decreases recurrence and decreases metastasis also if you lose weight. Decrease weight and physical activity, decrease recurrence, and decrease even different cancers. Antioxidants decrease cancer. Bariatric surgery decrease hormone-related cancer, limbic system, thalamus, hypothalamus, amygdala, and hippocampus. Post-gastric bypass hypoglycemia, you need to give ascorbose, octreotide, calcium channel blockers, and diazoxide. No pregnancy for 18 months after bariatric surgery. Stop estrogen in premenopausal women for 1 cycle, postmenopausal for 3 weeks. Respiratory quotient of carbohydrate is 1, for protein is 0.8, for fat 0.7. Lean people, there's increased bacteroids but less firmicutes. That came in the test. Stage 4. BMI predicts mortality. Obesity is early. PCOS is common in Spanish people, Mexican people, Native American, but the worst, the severest, in most severe in the South Asian Indians. Obesity is the most common medical problem in pregnancy. Obesity causes birth defects in fetuses. Preeclampsia, decreased weight. Preconception, decrease of the weight. Decrease the gestational diabetes by 25%, macrosomia by 30%, 7 kilos. Preeclampsia, breastfeeding, decrease breast cancer, ovarian cancer, CVD, diabetes mellitus, and death from CVD. Very, very amazing results. Breastfeeding for babies, decrease CVD, decrease obesity. That came in the test. If you suspect Cushing syndrome, came twice in the test. You do 24-hour cortisol test, 1 milligram dexamethasone suppression test, or salivary gland cortisol level at 11 p.m. DEXA has a problem with the high BMI above 35. So below 35 is the standard of care, but above BMI, there are two techniques that are better than DEXA, but both of them are hydration dependent. It's BIA and BOD-POD. MRI and CAT scan are the best for people regardless of hydration. That's given a test as well. DEXA is the gold standard below 35 BMI. BIA can be coupled with DEXA. You can't have, for BIA, you can't have alcohol or coffee for 6 hours. No sweating for 6 hours, and BOD-POD, no eating for 1 hour and no exercise for 2 hours. 1 kilocalorie equal 4.1 kilojoules. Food, 60% of them energy, heat, and only 40% of them make ATP. Ketosis reduces hunger. Imagine that. Blacks have less body fat. That means the BMIs that they said that they are the most obese group is not true. Protein, carbohydrates gives you 4 kilocalories per gram, and proteins and carbohydrates. Fat will give you 9 kilocalories per gram. GLUT2 in the liver, GLUT4 in the muscle and fat, GLUT5 is in the intestine. Requirements: carbohydrates 130 grams per day, fat 30 grams per day, protein 0.8 to 2 grams per kilogram per day. Names: Soul, It's a study for oral semaglutide in diabetes mellitus. Select study for semaglutide in obesity. Gourmand syndrome, damage to the frontal lobe, and he eats gourmet food. Stemmer sign, you can grasp the skin of the top of the second toe to differentiate between to make sure that this is lipedema, not lymphedema, that came in the test. Tanner sign came in the test as well for puberty. Weir equation, we talked about it. Energy expenditure, equations, Harry Benedict and Sanjor. Russell's sign is a callus at the knuckles, that's for bulimia. Pre-pregnancy obesity, increased obesity, and all complications of obesity in offsprings. Lipedema, autosomal dominant. Actually, obesity, that means you're going to have a family member that has it. Came in the question before. Obesity decreased subcortical gray matter. Obesity with cholelithiasis, nephrolithiasis, and glomerulopathy and gout. Metformin decreased cardiovascular disease and diabetes. M1 macrophages increases inflammation in obese, and M2 increase in lean individuals will increase IL-10 and TNF and TGF2. Sometimes chronic leptin stimulation can result in a leptin deficiency, and then in the acute necros, PTB1B, and that results in insulin resistance. Chronic leptin stimulation, leptin resistance, and insulin resistance. Leptin effects, some of the effects of the leptin, insulin, decreased insulin secretion, decreased glucose uptake, increased glucose uptake, decreased glycogen, decreased steroids, and increased TSH. Blood 2 liver or no. Ceramides are sphingolipids that can actually result in death of the cells in the pancreas. But weight loss, you can have recovery actually. There's a term called metabolic inflexibility of the cells that comes with obesity, and that actually results in cell death. 1/3 of IL-6 comes from the adipocytes. Phentermine, no increase in major cardiovascular events, but don't use it anyway in major cardiovascular disease. Acronyms, for motivational interviewing framework, the acronym is FRAMES. We talked about it before. Motivational principles, it's called RULE. Motivation interviewing skill, it's called ORS. Criteria: pediatric BMI less than 5, underweight 5% of the peers, 5 to 85% that's normal, 85 to 95% that's overweight, 95 to 99 that's obese, above 99 that's severely obese. Okay, obese and severely obese. When they found that kids broke these charts, they didn't want to change the charts. They're hoping that to hopefully treat this epidemic. So then they took this 95, which is the beginning of obesity, and they classified into class 1, 2, and 3. And that's why you see 95 to 100 percentile of the 95th percentile. So they made out of those categories more, but they didn't want to change the whole chart to match the American population at this time, hoping that we'll fix it. Class 2, 120 to 140 of the percentile of the 95th percentile, and then class 3 more than 140% of the 95th percentile. Body dysmorphic feature, concern about a subtle thing that nobody else can see, regular checking in the mirror and grooming, and then affect function, and it cannot be explained by any other eating disorder. Metabolic syndrome, we talked about mortality. For lap band, 0.05%. For sleep, 0.03%. Sleep, 0.05%. For Roux-en-Y gastric bypass and any other type of gastric bypass, 0.09%. But the renal switch is actually 0.4 actually, so it's a little bit higher than most of them. Contraindication for aspire procedure, when they aspirate from your stomach, not less than 22 years of age, not less than 22 years of age, BMI outside 35 to 55, binge eating disorder, abdominal or gastric surgery, esophageal stricture, gastric outlet obstruction, inflammatory bowel disease, gastropathy, gastroparesis, gastric ulcers, bleeding, coagulopathy, anemia, lactate, physical or mental disturbances, supplements. Increased satiety, guar gum, psyllium, which we know, prebiotic fiber, which we know. These are the jobs or the mode of action of different supplements. That's easy to remember, this category, increased satiety. Now, decrease fat, basically. Yeah, that's increased shit in the stool. Decrease fat, that's called chitosan. Increase carbohydrate metabolism, chromium, ginseng, white kidney bean extract. Increase energy expenditure, yerba mate, ephedra, guarana, yohimbe, country mellow, and bitter orange. And the rest is increased fat oxidation. That's how you know it. And that is it. Good luck.